Hello everyone, welcome to sqadia.com, and in our first section of the lecture topic, Urogynaecology, we will talk about the urinary incontinence mainly, and then what's the urogynecology in itself. So in this section, we will talk about anatomy and nerve supply of the vesicourethral unit. And then what's physiology of micturition? What's the normal process and how it leads to urinary output or micturition? And what's urinary incontinence? So urogynecology, as the name suggests, is uro is for the urinary system, and gynecology refers to the study of female reproductive system. So combined together, it's known as urogynecology, and it's a subspecialty of urology and gynecology. The urinary system and the reproductive system are very, very closely linked to each other. So sometimes problems in the pelvic floor due to multiple gestations, multiple pregnancies, normal vaginal deliveries, all these can lead to relaxation of the pelvic floor that can ultimately lead to problem in the urinary system and leads to urinary incontinence. So they can be studied together as urogynecology. So anatomy of the vesicourethral unit. In this diagram, one is sagittal section of the vesicourethral system, and then the coronal section. In the sagittal section, it's the section that divides the system into right and left halves. So this is basically when we divide it into right and left. And in the coronal section, its organs are cut like in the front and back. So sagittal plane goes vertical, divided into right and left half, and coronal section goes like this horizontally. So it divides the body plane into front and back. So if we see the sagittal section of vesicourethral unit, here is the pubic symphysis. Pubic symphysis is the portion, anatomical portion where the two pubic bones come and combine together. So pubic symphysis is in the front where the two pubic bones of the two hip sides, they come and combine. So this is the pubic symphysis. And then this is the pubourethral ligament that combines pubic bone or attaches pubic bone to the urethra. This is pubourethral ligament. Then these are the ureter opening. Ureter opens into the urinary bladder, one on each side here, if you see. So these are the ureteral openings. And then the opening of the bladder into the urethra. This elongated structure is the urethra that leads to that carries the urine from the urinary bladder to the outside. So these are the ureters. Ureters bring the urine from the kidneys and open one on each side of the bladder. And this is the urinary bladder. And then this is the urethra that carries the urine outside the urinary bladder. This trigone, it's a triangular structure. Trigone is made up of the ureteral orifice here, two openings, and then the urethral orifice. All these three structures make up a triangle, which is known as a trigone. Tri means three. So it's a triangular structure, trigone, made up of the ureteral orifice, opening of the ureter into the bladder, and then the opening of the bladder into the urethral orifice. So this is we have the deep trigone, and then we have the superficial trigone. These are the muscles of the deep trigone. Smooth muscle, trigone is made up of the smooth muscles. So symphysis pubis, pubourethral ligament that attaches the pubic bone to the urethra. Then these are the striated muscle, intrinsic striated muscle. If you see here, attaching around the urethra. These are the striated muscle. So bladder itself is a smooth muscle here. Trigones are made up of smooth muscle, superficial and deep. Then we have pubourethral ligament, and then these are the intrinsic striated muscle attached on the sides of the urethra. And then here we have the submucosa and mucosal vascular tissue surrounding the urethra. So mucosal and submucosal tissues, striated muscle. Trigone is made up of the smooth muscle, pubic bones, and then trigone is a triangular structure made up of the ureteral orifice, 2 ureteral orifice, and 1 urethral orifice. So urinary system basically is composed of, we have kidneys included because urine is formed and stored in the kidneys. From the kidneys, ureter carry the urine to the urinary bladder. Here, urinary bladder, opening of the ureters, and then from the bladder it goes out through the urethra. So this is the sagittal section, and this is the coronal section of vesicourethral unit. Vesico is the term used for urinary bladder. Urethra is for urethral. So vesicourethral unit. Vesico is for urinary bladder, and urethra, we have 2 ureter orifice, urethral orifice, and then we have sphincters, which are the circular structures that open and closes to allow the flow of the urine. Then what's the nerve supply of the vesicourethral unit? As we discussed earlier, this is the bladder. These muscles in the bladder are the detrusal muscle. These are the detrusor muscles. Trigone is made up of the orifice of the ureter and then the urethral orifice. Here we have then there are these are the muscles that surrounds the urethra. We already saw these. These are the striated. If you see here, these are the intrinsic smooth muscles and this striated muscle. So striated muscles. From these muscles and from the detrusal muscle, once the bladder is filled with the urine, the nerve supply from the wall of the bladder carries the sensation to the midbrain or the brain here. And then from there, the message comes back to the bladder, and then the bladder empties the urine. So the nerve supplies mainly are the pudendal nerves. There are pelvic nerves, pudendal nerves, pelvic nerves, and then we have hypogastric nerve. All these carry sensations. Mainly they are controlled by T10 to L1. So thoracic 10 and L2, spinal cord. These sensations are carried to spinal cord at level T10 and L2, and then also at sacral S2 and S4. And then any injury to the lower back, usually the spinal cord at the T10 and L2 level usually cause problem with the urinary incontinence, and usually the bladder problems occur if there is injury to the lower back, because the nerve supply is mainly to the bladder is controlled by T10 and L2 and sacral S2 and S4 levels. So any injury at this level usually cause urinary problems. So nerve supply is mainly by pudendal nerve, pelvic nerve, and then we have hypogastric nerve. And the level at which it is controlled is from T10 to L2 and then S2 to S4. Again, the physiology of micturition. Micturition is the process of urination. The term used for urination is micturition, and physiology is the normal mechanism. So normal mechanism of urinary or urination is mainly here once the bladder is filled and there is contraction of the detrusal muscle or detrusal contraction, then the information goes to spinal cord at S1 to S5 level. This is sacrum 1 to sacrum 5, and then this leads to supply of information to the hypothalamus in the brain, which in turn send the impulses and leads to the urinary output. So mainly all this is regulated by the nervous system. Once the bladder is filled, the impulses goes to the hypothalamus in the brain, and then the hypothalamus sends the relay the information to the bladder. Bladder then contract and leads to the process of micturition. So this is the radiographic tracing of the bladder and urethra during the process of micturition. This is the full bladder. If you see, this is the full bladder at rest, and this is the bladder during micturition when you can see it's shrinking and the muscles are contracting. So once the detrusal muscle contract, pressure inside the bladder increases and it leads to the process of micturition, and it is controlled by the nervous system. And once the contraction of the detrusal muscle occur, there is a sensation to the hypothalamus. Hypothalamus then relays the information, and then the process of micturition takes place. Again, this picture shows you these are the stretch receptors. In the wall of the bladder, there are stretch receptors. So once there is stretching of the muscle of the bladder takes place, they'll send the information through the sensory afferent. Afferent are the nerves that carries the information to the brain, and from the brain efferent vessels comes out. So sensory afferent vessels carries the information to the brain, and efferent carries away from the brain. So once the stretch receptors in the bladder, they stretch as a result of contraction of the detrusor muscle, they carry the sensation through sensory afferent nerves to the brain stem here, and then it comes from the brain stem, it goes to the ganglion, parasympathetic ganglion, which carries the information to the bladder and then leads to the emptying and contraction of the bladder. And then also from the brain stem, From the brainstem, there is another information comes through the somatic efferent here through the sympathetic ganglion, then post-sympathetic ganglion to the urethra, where there are sphincters in the urethra, and it causes opening of the urethral sphincter so the urine can come out. So all this, as we mentioned before, starts with the pressure in the urinary bladder. Once the urine is collected, pressure is built up in the bladder. There are stretch receptors in the wall of the urinary bladder that send the information to the brainstem, and then the brainstem instead carry the information through the efferent vessels or efferent nerves to the bladder, and then the bladder in turn contracts. So parasympathetic mainly is responsible for the stimulation of the bladder, and sympathetic nervous system or sympathetic nerves mainly responsible for the control of the urethral sphincters. Urethral sphincters are the ring-like structure. One, we have internal urethral sphincter and external urethral sphincter. Internal urethral sphincters, they are involuntary. Under involuntary control, person has no control on the internal urethral sphincter. But external sphincter, it's voluntarily we can control it. So if there is strong urge to urinate, we can control the external sphincter, and for up to a certain limit we can control the opening so the dribbling or the urination cannot take place. So during this, if you see bladder here, once the pressure in the bladder increases, detrusor pressure, or the muscles inside the bladder, the detrusor muscle, they contract and they put the pressure on the bladder. Muscles of the pelvic floor, they elevate and they cause the urination to occur. And also abdominal pressure act on the bladder also here. So that's what happens in all the problems of urinary incontinence, that if due to relaxation of the pelvic muscles, once the pressure in the abdomen elevates and it causes increased pressure on the bladder, even with involuntarily, sometimes there is dribbling of the urine because the muscles become relaxed and they cannot control. So this is once the abdominal pressure act on the bladder, there is contraction of the detrusal muscle. Detrusor pressure rises. The muscles of the pelvic floor also elevate, contract, and it causes process of urination to take place. Then kinking of the urethra. This is the urethra. If the kinking of the urethra takes place, it also elevate the bladder, neck upward and forward. So these are some changes that takes place, leads to urinary continence. Then we have urinary incontinence. What's the classification of urinary incontinence? It can be urethral or it can be extra-urethral, outside the urethra. So urethral causes of incontinence are It can be due to urethral sphincter incontinence, which is known as the genuine stress incontinence, GSI, genuine stress incontinence. So urethral sphincter incontinence. Sphincters are the ring-like structure that open and closes to allow the flow of the urine. So if those are not opening or closing properly, it can lead to the urinary incontinence. Then detrusor overactivity, DO. Detrusor are the muscles present or in the bladder, or sometimes even the bladder is known as the detrusor also, because it's all the detrusor muscle. So detrusor overactivity or bladder overactivity, when they are overacting or over contracting, that's the detrusor overactivity. Then in mixed type, both there is sphincter incontinence and detrusor muscle overactivity. Then we have overflow incontinence. It can be acute, short-term, and chronic, long-term. And as the name shows, overflow incontinence. Sometimes bladder become overfilled, that it exerts so much pressure on the sphincters that they open up and there is urethral and then there is urinary incontinence. That's the overflow incontinence. Then we have functional and other different types of urinary incontinence, mainly the neurogenic incontinence, because as we saw before in the nerve supply and the physiology, nervous system plays an important role. So if the signals are not coming properly, or if there is injury at the spinal cord level from T10 to like S5, it leads to incontinence problem. And then we have the congenital, in which there is a problem to the opening, urethral openings and the epispadias, that also leads to incontinence. Then some extra urethral causes, it can be divided into acquired or congenital. Congenital, which are by birth, and acquired, which are through some abnormalities. And acquired can be due to problems in the bladder vesicle, then problems in urethra, and it can be due to problems in the ureters. And fistulas. Fistulas are the openings that are formed. Fistulas, or the junction between two organs, leads to fistula formation, and that can also lead to the incontinence. Congenital problems can be due to ectopic ureter and other problems. Ectopic ureter is when ureter is not placed properly. That's ectopic ureter. So that can be a problem in incontinence. So different causes can lead to incontinence, which can be urethral and extra-urethral. Now, the urinary incontinence is of different types. Here we mentioned different types of incontinence. Can be irritative, stress incontinence, urge incontinence, overflow incontinence, and bypass incontinence. And the irritative incontinence is mainly due to infections, urinary tract infections. So in this case, usually urinalysis. UA is for urinalysis, in which urine is examined. Usually there is increase in white blood cell count, or if the culture is done, usually some bacteria is present. So urinalysis and culture test, urine culture sensitivity testing is usually abnormal in this. So irritative is due to infections mainly, and urinalysis and culture sensitivity test is abnormal. Treatment is usually antibiotic and the cystoscopy examination to see if there is any abnormality. Then the other type of incontinence is stress incontinence. So, stress incontinence, usually there is loss of bladder control, and increased abdominal pressures usually leads to stress incontinence. And contraction, detrusal contraction is usually absent in this because again there is loss of bladder control mainly due to increase in the pressure in the abdomen that cause pressure on the bladder and leads to incontinence. And in this, the retrusal contraction is absent. Urethropraxy is commonly done to fix this problem, in which there is support is given to the urethra so it can hold the pressure better. Then the third type is urge incontinence. Urge incontinence, here the detrusal contractions are present. In this, the bladder control, usually there is bladder control, contraction of the detrusal is present. So there is strong urge to urinate. Usually the urine inside the bladder is hypertonic and involve the control of the bladder. So urge incontinence usually is treated by anticholinergic and non-steroidal anti-inflammatory drugs because it sometimes leads to the painful bladder also. There is strong urge to urinate, and there is contraction of the uterus. So in some cases, usually there is any obstruction to the urethral outflow, and once the bladder is too full, then there is strong urge to urinate. Then in this overflow incontinence, detrusal contraction is absent and there is increased residual volume present in the urine. So once the patient urinate or micturate in this type, usually the residual urine, lot of urine is left behind. Here if you see, the bladder is still filled with the urine and there is lot of residual urine after the micturition. So that's overflow. Bladder is so much filled with the urine that there is dribbling of the urine. So overflow. And then there is bypass, is incontinence. Usually there is continual leakage of the urine, and usually this occurs mostly in the fistulas. If there is a connection between urinary structure and other organ, then there is constant leaking of the urine, and this is mainly in the fistula bypass. These are again some common types of incontinence we already mentioned, but they give you the diagrammatic information about what's the position of the urinary bladder in these different types of the incontinence. If you see overflow incontinence, here there is a blockage to the urethral blockage, and then bladder unable to empty properly. Overflow, there is bladder so much residual urine. Residual urine is the urine that is left in the bladder after the process of micturition or urination. That mainly occurs when there is obstruction in the urethra, like some stenosis or stone that leads to incomplete evacuation of the bladder. So this pressure in the bladder increases because there is residual urination, and there is overflow incontinence. It's filled so much that it put pressure on the urethral sphincter and some leakage of the urine occurs. Then in the second stress incontinence, there is relaxed pelvic floor. One, in the overflow, the cause was obstruction to the urethral. In the stress incontinence, the pelvic floor becomes very relaxed. This type is mainly occurs stress incontinence in females who are obese, who have multiple pregnancies, multiple gestations, and then normal vaginal deliveries without some good gynecological care that leads to relaxation of the pelvic floor muscles. And once the abdominal pressure is increased due to coughing, sneezing, they leads to dribbling of the urine. Very common with the increased age and increased weight of the patient. So in this, there is relaxed pelvic floor and leads to the increased abdominal pressure leads to the incontinence of the urine. Then in the third type, if you see urge, there is urge to urinate, bladder oversensitivity from infection. So if there is infection, usually leads to their urge to urinate. Patients keep on going to restroom because they keep on feeling the urge to urinate, but once they go, they just pee or just dribble a little bit and then they come back. But again, they need to go and they have the urge to urinate. So this is mainly due to infection or due to neurological disorder. So three main common types of incontinence we went over: stress incontinence, there is urge incontinence, and overflow incontinence. Overflow is due to obstruction. Stress is due to relaxed pelvic floor. And third, urge incontinence is mainly due to infections and due to neurological disorders. Thank you for watching sqadia.com.